Hello, I'm David Kandzari, Director of Interventional Cardiology and an interventional cardiologist at the Piedmont Heart Institute in Atlanta, Georgia. And welcome to Seoul, the TCT Asia Pacific 2014 Scientific Sessions. I'm joined here for the TCT wrap-up with regard to the topic of left main and bifurcation disease with some key thought leaders in the field of both interventional and surgical cardiovascular medicine. We have together here David Taggart, Dr. S.J. Park, and Dr. Yves Louvard. So it's terrific to have all three of you here for this discussion. And we want to begin with some of the technical aspects of left main percutaneous revascularization. That's going to transition us into a discussion a little bit of some of the more recent outcomes data. We're going to bring David into that discussion with regard to the decision making around bypass surgery. And then we'll maybe conclude perhaps with a discussion of where we're heading with regard to complex coronary revascularization, the concepts of the heart team, some recent trials that are ongoing, some recent trials that SJ, and your colleagues have presented here at the meeting as well. SJ, let's begin with you in a discussion of left main PCI in general. I think everybody recognizes globally you and your group have been leaders in advancing this field and the science around it, not only from the clinical outcomes perspective relative to surgical revascularization, but the technique as well. In particular, the use of Yves and FFR for left main and complex bifurcation disease. Mm-hmm. What are some of the most recent advances we have here that we've learned from these sessions too about the use of Yves, the use of FFR, and just technique for left main PCI in general?
Right. For the main ostial shaft lesion subset, actually intermediate stenosis concerns of between the 40 to 85%. Still, FFR is very much crucial, right? I think so. The reason why is angiographic evaluation of ostial shaft lesion and main disease is very much barriers in intra-observers, inter-observers, and so for the accurate diagnosis concern, FFR is very much crucial. And even in the bifurcation disease, this is involved in the true bifurcation side. The degree of stenosis, intermediate stenosis concern, still, I would think it's a composite FFR. If you place the transducer distal part of a TGG unit, still composite FFR works to define functional significance of stenosis. And so, treat or not treat concern, right? Decision making is still FFR work. And inside of Yves guidance, actually there are more information from the inside of understanding of the plaque vulnerability, reference vessel diameter, etc., etc. And so, I would say kind of FFR would be related with decision making, treat or not treat, and Yves guidance mainly related with procedure optimizations. We have lots of data about that, and so that is my thought.
Let me just step back for a moment about some of your comments on FFR, SJ, because I think they're very relevant in decision making beyond left main disease. And we're going to talk about risk models a little bit further. I'm very interested in David's perspective too on syntax score and other models too, but there's a concept raised of the functional syntax score, where we perform FFR on all three major vessels, and then based on the hemodynamics, we make decisions. And there's this concept that you would take a patient with a high angiographic syntax score, and there'd be a downward shift, a paradigm shift towards a lower functional syntax score. And it's hypothesis generating to think that if you use the functional syntax score and we performed more smart PCI, so to speak, Yves, if we perform more selective PCI, that perhaps instead we might have outcomes that might be more competitive to the benchmark standard of bypass surgery. Is that a fair guess at it, Yves, or not?
Normally the patients are scheduled for outpatient coronary angiography when they come in our center, excepted of course the acute coronary syndromes. And I think that the FFR is a part of the diagnostic period. So during this outpatient coronary angiography, if the patient has a multivessel disease, we test all the apparently significant lesion. And then we schedule the patient for this complex intervention in multivessel, which is sometimes no more a multivessel disease. And regarding the remark of S.J. Park on the Yves, we are not in France. We are not reimbursed for any imaging, not OCT, not IVUS. So we are only minimally using the IVUS. But what we did and what we still ask to do to our younger colleagues is to perform for the first 50 left mains have to perform IVUS. Because even if we don't do routinely IVUS, at least the young operators may learn the lesson of IVUS. The left main is big, the diameter of the left main, diameter of an LED are not the same. And we are not routinely doing guidance with IVUS. We lack the IVUS of poor people, I will say, which is the formula relating the 3 diameters of the left main. If we have at least 2 normal vessels, we can measure the 2 diameters, calculate the diffuse disease, the real size of the diffuse disease left main. So we are working like this. Of course, at the end, if we have not satisfied, so it's not doing routinely IVUS at the beginning, but at the end, if we are not satisfied, we can perform IVUS to confirm that the size is good, that everything is opposed, and so on.
Now, as that takes us to the discussion about IVUS, SJ, you've commented frequently that IVUS saves lives. And what is meant by that, and what is the translational mechanism of IVUS to saving lives?
All right. You know that there are very limited data, right? Actually, only published data is from the main compare registry data, separate with match it, adjust the match it people. IVUS guidance has better survival rather than angio-guided procedures. Actually, we cannot explain the reason why. The case by case is. However, look at this. We can choose by IVUS guidance a little bit bigger stent size. Anyways, we can make a big stent cross-sectional area, and we can evaluate some kind of a stent opposition, how much is geographic this, etc., etc. And so there are lots of small information during the procedures that may, gathering the information would be influenced later outcomes. And if you look at it, very difficult to, discriminate a random study, something like that. However, many meta-analyses, actually we just published our, IVUS guidance meta-analysis, including the 23,000, patients, is clearly better outcome in hard endpoint concern. And so I believe IVUS guided, very small, information, however, get together can make a good clinical outcomes.
Why not performing a randomized trial?
It's almost the reason why the randomized study is so difficult. Even if you do angio-guided procedure, right? However, if your way of thinking have already influenced the IVUS, right? And so it's not fair in terms of angio-guided, IVUS guided. We cannot make any difference, right?
I agree. I think that the utility of it has been now so ingrained in our practice based on your data of achieving minimal luminal area thresholds, as an example, at the ostium of the circumflex, the LAD, the polygon of confluence, the shaft of the left main. My colleagues as well, they've taken on to it that for all of our left main cases, we, like you, we're not reimbursed, but we uniformly use IVUS for those purposes, which takes us now to beyond technique, and I want to come back to technique on bifurcation disease in a little bit if we have a moment too, but it reminds me of some data that Yves and I were privileged to be part of a panel today for some of the late-breaking session data, and that was regarding the pre-combat data that was the 3-year follow-up of this study. So recall, this is a 600-patient randomized trial performed in Korea. Exceptionally well-done study randomizing patients with left main disease, an average syntax score of 25, 300 patients randomized to the sirolimus-eluting stent, 300 patients randomized to bypass surgery. The study at 1 year, just to review for all of us, showed no major differences in death, MI, stroke, but higher target vessel revascularization.
Exactly.
At 3 years follow-up, again, almost paralleled outcomes. Outcomes increase in both groups, events increase rather, but no major differences. 6% rate of death, myocardial infarction, and stroke at 3 years for surgery, 6.1% for PCI. But when you include TLR, or clinically driven repeat revascularization, it's still, of course, higher with the drug-eluting stents. So first comment I had, takeaway, is that's a pretty low event rate at 3 years, because the Excel trial, as we'll discuss, is estimating 11% at 3 years follow-up. So, David, what's your take on data like this? And you've made some comments earlier today about the importance of assessing endpoints at later time frames rather than at, say, 6 months or 1 year. What are your thoughts on that?
Yes, well, I think these are very good points you've raised. And just to set the scene, if you like, I mean, we discussed this morning that even 6 years ago in the literature, the widespread view was that the only effective treatment for left main was bypass surgery. And that was widely reflected both in the literature and indeed in the guidelines at that time. And it's all credit to leaders like Dr. S.J. Park through initially the main COMPARE registry, and then, as you've mentioned, the pre-combat trial that really made us begin to seriously change our consideration of this. And if we now look what's happening with pre-combat and with syntax, then we're totally changing our view of the treatment of left main. And if you summarize the evidence in totality, certainly patients with syntax scores below 32 for left main, so that would have been many of the patients in pre-combat and a large proportion of patients in the syntax trial, the evidence is increasingly apparent that these patients do at least as well with PCI, if indeed possibly not better than with surgery. And my own view of this now is that it may reflect the fact that in the lower severity left mains, where you do not have additional proximal coronary artery disease, there may simply be too much competitive blood flow for bypass grafts.
That's an interesting postulate, because I think maybe 5 years ago, too, we would have just said left main, 3-vessel coronary disease, it's kind of all one bucket, right? It's all one complexity. And now I think we see that left main is really its own disease entity separate from 3-vessel disease. SJ, you made some comments about this earlier today, right? And I think that, and so coming back to that issue, though, David, I think is the syntax score the best step we have right now forward, or do we need to be using some other type of risk model to identify these patients?
I think the syntax score is a major step forward in the sense that it's helped us all clarify our understanding of how important the severity of coronary disease is, either with left main or simply proximal coronary artery disease. And one has to bear in mind now, the importance of the syntax score is recognized in the way that it's formally written into guidelines, and it's used very heavily in the European guidelines to classify severity of coronary disease. Your question implies, is it the best scoring system we have? And the answer probably is not, but it's an incremental process. It's much better than before when we didn't have a scoring system as good as syntax, but there are probably better scoring systems available just now, especially those which add the functional relevance to patients in terms of patient comorbidity.
David, you mentioned about functional syntax scores. Actually, even in the functional syntax scores, still risk stratified by morphology complex concern parable, right? However, I like the Tony Notes data. So you may know that, right? Angiographically 3 vessels, 100 patients. If you do FFR, just only 14% of a patient and truly 3-vessel disease, remaining 2-vessel in single-vessel disease. And if you look at the high syntax scores, I know that there's even the high syntax scores mainly contribute to the 3-vessel disease, mainly the 3-vessel disease. However, if you look at the separate with the 3-vessel disease, functional concept with the FFR, just only 14% of a patient had a truly 3-vessel disease.
Yeah.
I think it's a totally different concept, right? Different work. And so as we combine with any functional, concern and morphology concern, is a little bit different. The meaning is, morphology concern, why it is important for anyways to how to treat something is, however, based on the many data, registry data, analyzed data, and morphology concern actually cannot influence too much about the late clinical outcome. The reason why, even in the after the FFR measurement in the high syntax score is getting, just my,
Let me maybe move this discussion one level beyond syntax, and let's just think of it as completeness of revascularization and the relevance for that. Now we know from very experienced centers, David, in Europe doing the syntax score, let's just take the example of chronic total occlusions. Many of them were not surgically bypassed. Obviously, many of them were not treated percutaneously. That alone was an independent predictor of incomplete revascularization. And overall incomplete revascularization, whether surgical or PCI revascularization was undertaken, was a harbinger of bad outcomes over time. Is it another way of thinking about it independent of the syntax score? Might we think that, look, can we just achieve complete revascularization or not, and then either strategy is okay? Where does that come into play?
It's a very good question, and it's very informative to look at syntax at 5 years and look at incomplete revascularization. Because what you see is when the surgical group had incomplete revascularization, it made no difference to their clinical outcome. Whereas in the PCI group, incomplete revascularization seriously affected outcome. So how do we tie these two things together? And it's to understand the concept.
I know where you're going with
this.
When
you talk about incomplete revascularization, you have to define whether it's appropriate or inappropriate. So for example, during a surgical operation, the surgeon would never leave a large vessel unrevascularized, say a chronically occluded vessel, but he may look at a small vessel supplying a small amount of myocardium and say, there's no point putting a bypass graft. So in terms of surgery, it's very unusual to have inappropriate, incomplete revascularization. But it's different for PCI because the degree of completeness of revascularization depends on the technical complexity of that lesion. So you may have a large occluded vessel that you cannot open percutaneously, but which, had you performed surgery, would have been opened. And I think this is the difference in the outcomes between these, between what the functional relevance of incomplete revascularization is, and it's understanding whether it was appropriate incomplete revascularization or inappropriate incomplete revascularization.
Yves, does this influence your practice, the decision-making of complete versus incomplete, or is it more a syntax score issue?
Because we are biggest center for CTO in France, performing 230 a year. So I think what we can propose is to propose a functional center score plus comorbidity plus for the PCI real feasibility all the significant lesions. And I agree with Dr. Taggart that we can forget small branches as do the surgeon. But for major vessel, if we are not able, or we think we won't be able to succeed in a complete revascularization, probably a good reason to move to surgery if it's feasible.
Now,
so we have three fields: feasibility, functional, and comorbidity.
Yeah. One of the colorful discussions today, too, was if there's a particular stent that might be better than another for multi-vessel and left main revascularization. I'm going to ask SJ and Yves about this in a second. But in this discussion, I think, David, you had some comments about the surgical bypass graft. And I think this is also a little bit relevant to completeness of revascularization because the graft is providing bidirectional flow once it's implanted. And so unlike a stent where you're reliant on that stent, if disease progresses further in the target vessel, distal or proximally, you're protected by the graft. I have a question, though, for you, too, David. Is it fair to say that many surgeons would acknowledge that bypass grafts accelerate native vessel coronary atherosclerosis? Is there any element of that?
Yeah, so two issues here. If I may just go back and address the first issue of, by placing the bypass graft to the mid-coronary vessel, it doesn't then really matter what happens in the proximal coronary vessel if you develop further disease. And we see this in syntax because if you look at 5 years between PCI and surgery, you can see that every year there's an increase in the incidence of myocardial infarction in the PCI group, but you don't see it in the surgical group. The incidence of myocardial infarction plateaus at 1 year in surgery, but it increases year by year in the PCI group. And I think what that's telling you is that the bypass graft is giving a protective effect to the coronary vasculature. Whereas regardless of the type of stent you've used, if you get additional proximal disease, either proximal to, within, or immediately distal to the stent, whatever kind of stent you've used, its beneficial effect is mitigated. In terms of do you get promotion of coronary disease in vessels that have been grafted, this is widely stated. But to be honest, I haven't seen good evidence to support that actually happens. I've heard it frequently stated, but I've not seen a good manuscript saying that placing a graft causes new disease independent to progression of disease in these patients. Because remember, many of these patients have a chronic disease that will progress with time.
Even in saphenous graft.
Oh, no, sorry, I meant in the native circulation.
In the native artery, yeah, I agree. It's how do you distinguish what the graft might or might not be doing versus the natural history of the disease
but
as well.
If I may make one final comment on that, what we certainly know, and there's very good evidence produced by Tom Lusher, that if you place a mammary artery on a native coronary vessel, not only does the mammary artery stay patent, because presumably the most obvious reason is the amount of nitric oxide it produces, but elution of that nitric oxide into the native coronary circulation certainly protects the native LAD.
Let me transition that to the stent issue then. So when left main PCI is performed, SJ, and then I'll ask you, Yves, is there a difference between newer generation DES and pre-combat with sirolimus-eluting first-generation DES?
Yes, we have some, consecutive pre-combat series study to evaluate the new drug-eluting stent compared with a Cypher, and everolimus eliciting giant speed, promise element, resolute integrity. Anyways, we have consecutive, historical comparison with the Cypher. Actually, we didn't find any difference, especially for the second generation of drug-eluting stent. I believe that there may have no difference in terms of clinical, adverse outcome. The meaning is main artery itself is relatively big one, proximal artery, and so the small difference cannot make any big difference, right? And according to the different drug-eluting stent. However, even you may remember that these are the main studies, Cypher versus Texas, no difference at all. So for the main intervention, the meaning is I do much believe about the Texas stent anyway, the lay loss is high, something, etc., etc. However, still no difference in the main PCI concern. And so I think it's a second generation of drug-eluting stent, it would be good for.
Yves, I have to believe that we can do better than the high rates of stent thrombosis, 10% definite probable at 5 years that were reported with paclitaxel-eluting stents in the Syntax trial. I think what's striking that is about 19% of the stent thromboses in Syntax were attributed to the left main, which seems unusually discordant from all of our other data. Is it going to make a difference with newer DES? And comment too, having BVS available to you, is this the next role for BVS in left main disease?
First of all, BVS is not available in France. It's CE mark, but it's not reimbursed. So practically, we cannot put in patient except in the foreign people with a lot of money. But we have a comparison between everolimus and Taxus, which was in 2 different studies in left main, performed in the same 5 centers. And after, with the Taxus and with everolimus, the result that follow up, I think it's 3 years, it is much different in favor, of course, of everolimus, because we can say that in the Syntax group, the highest tercile of Syntax trial in everolimus is doing better than the lowest tercile in Taxus trial. So we see a very clear improvement comparing the Taxus and the Xience in left main plus other lesion populations.
Yeah, I'm not sure that BVS, this is the exact spot for BVS in the future anyway, at least with the current design of the stents. I think there are scaffolding issues. I think there are strut thickness issues. We don't really care so much if the stent dissolves or not in the left main. It will get bypassed regardless. I think restenosis would be an issue, and that might be an advantage for BVS. But more to come, I think, as that technology develops itself. Let me just touch in the last couple of minutes on technique for bifurcation disease in general. Then I want to bring this back to our decision, finalize a decision making about what we do with left main disease today. Let me ask you, Yves, just given some of your comments earlier today and some of the sessions for bifurcation disease in general, are we still staying with the same themes of less is more, single stent when available, and when 2 stents are needed, what's the optimal technique?
when two stent is needed, frequently we know that after already putting a stent in the main vessel. So if we cannot speak in kind of techniques, we have to speak in kind of strategy. So is the access to the side branch so complex that we have to put a stent in the side branch first? This is the main question. If the answer is no, I think we can perform all the bifurcation stenting, beginning with the crossover, with the technique we discussed already several times today. We first put a stent across the side branch with a protective wire. Normally we avoid predilatation of the side branch, but sometimes we have to relieve a calcified lesion with undersized balloon. Then, after crossover stenting, we immediately optimize the proximal part, which is we call the pot. It changes completely the access to the side branch. For putting a balloon, if we need to put to do a kissing balloon, that is discussed. But for a very big side branch, I think even without severe lesion, I think for the circ, for example, I think it's important for me to do a kissing balloon. And after that, this is a very fluid technique. You can decide everything at each time, at each step. So if the result you get with a single crossover with a small side branch is good, don't do anything more. If the result is not acceptable in the side branch and you have to exchange the wires, which is normally easy with a gel wire, and you can do a kiss. And sometimes after a kiss, if the result is again not acceptable, you can do a second stenting. So the double stenting, so-called double stenting techniques, are not only stenting beginning with the side branch. And I said that already this morning, that during the last recent years, I have not performed double stenting beginning with the side branch, except in the BBC2 trial we just finished a few weeks ago. So I think putting a stent in the main vessel first is always feasible, or near always feasible.
SJ, when two stents are needed up front, based on your extensive database, is there any one two-stent technique that might be favorable than another?
Right. Non-main bifurcation, as I totally agree with your strategy and opinion. However, main bifurcation, I think, is a little bit different. So anyway, after the understand about the functional concept, more use of FFR and IBUS, so we prefer single stent crossover. The frequency of main stenting is getting more. 70% of cases we do just a single stent crossover. So, however, if you look at some data, the angiographic guided procedure, something two stent still higher restenosis rate TLR rate rather than the single stent crossover. However, David, you mentioned about IBUS optimization. Whatever you choose the two stent technique, different any mini crush T stent technique. I think the most important thing is stent cross-sectional areas after the two stent technique. And
so it doesn't matter the type of technique,
yes,
it matters the result that you get,
I believe that. And so if there was a silicon disease by visually, by IBUS guided, they are pretty much flag, why not? We're going to choose the two stent. However, so we have to keep in mind the kind of 5, 6, 7, 8 millimeter scales IBUS guidance optimization can make less than 5% restenosis rate and 2% of a TLR rate. And so,
valid comments. David, I'm going to finalize with the last comment from you. I sit here and I look at us, and we're 4 different countries representing 3 different geographies. The Excel trial has completed enrollment. We're resting on a wealth of data from pre-combat, from syntax. Nothing else really coming forward until that time. Until we have Excel, patient with an intermediate to low syntax score, left main disease, what do we do with these patients? What do we recommend? Do we still stay with surgery as a standard until we get the result? Can we offer PCI to these patients ahead of time?
I think with the wealth of evidence we have today, as you said, we're awaiting Excel and the Noble trial. I think today for patients with isolated ostial and midshaft lesions, there's a very clear mandate to offer almost as a treatment of choice PCI now. I think if you have any type of left main with significant additional burden of proximal coronary artery disease, I think the left main is irrelevant, because we know that these patients do better with surgery anyway. And then there's that group where I still have some dubiety as to what we do, and that's for the true tight distal left main lesions, particularly the bifurcation lesions. There's evidence that these do better than we initially thought 10 years ago with PCI, but I don't think the data for those is as clean as it is for ostial and mid-shaft. So ostial and mid-shaft, I think a clear mandate to progress with PCI. Significant additional proximal coronary disease. If the patient has no strong comorbidities, I think surgery still should be the treatment of choice. And for the distal bifurcations, I still think it is a grey area.
Well stated. I want to thank you, David, SJ, Yves, for all your thoughtful comments and educating me. I always learn from all three of you. So thank you again for this session. Thank you.
Thank you very much.
Thank you.